Welcome to The Confident Nurse. I'm Nate, here with Andrea, a trauma nurse with nearly 20 years of experience. This series breaks down the key takeaways from the trauma shock and resuscitation course. We're pulling out what really matters, the practical lessons, the tough calls, and the insights that can make the difference when seconds count. We're synthesizing material on trauma shock, precision resuscitation, basically the knowledge that can genuinely separate a devastating outcome from one that's survivable.
This is a deep dive into the physiology of crisis. Success in trauma management, it really boils down to structured assessment, recognizing problems early, and precision intervention, especially in that critical window.
Yeah, the golden hour of survival. So for you, the learner, we're aiming to lay out the framework, and importantly, the clinical evidence that drives today's modern trauma protocols. Let's start right at the beginning, like down at the cellular level. When we talk about trauma and shock, it's more than just low blood pressure, isn't it? There's something more fundamental going wrong.
Absolutely. At its core, shock is essentially an oxygen delivery failure,
Oxygen delivery failure, so the tissues are starved of oxygen.
right? It's a state where the perfusion to the tissues, the blood flow is just inadequate to meet the body's metabolic demands. Think about the mitochondria in the cells, the powerhouses. They need oxygen for efficient energy production. That's aerobic metabolism. When that oxygen supply dwindles because blood flow is poor, the cells basically panic. They shift gears. They switch to anaerobic metabolism.
And that anaerobic shift, that sounds bad. What are the actual consequences? What happens then?
Oh, it's catastrophic. Anaerobic metabolism is incredibly inefficient. And worse, it produces a massive amount of lactic acid as a byproduct.
Lactic acid.
Yeah. This buildup leads to metabolic acidosis, which is frankly toxic to cells. It messes up critical enzyme functions, reduces the heart's ability to contract properly,
So the pump gets weaker too.
precisely. And it ultimately starts that downward spiral towards multi organ dysfunction syndrome. So, the goal of rapid intervention is really to reverse this cellular oxygen debt before that damage becomes irreversible.
Okay. Our sources break shock down into four main types. Hypovolemic, that's the big one in trauma, right?
That's right, Nate.
Massive blood loss, like from trauma or internal bleeding, where the body loses circulating volume so fast that tissues can't get enough oxygen or nutrients.
That's the most common.
But how do the other three categories kind of complicate the picture, especially if you've got a patient with injuries all over the place? In cases of multi-system trauma.
Right. So, hypovolemic shock from acute hemorrhage, blood loss, that's definitely the dominant player in trauma. It accounts for the vast majority of those early preventable deaths. But you have to be alert for the others.
Okay.
So, first, you have distributive shock. Think of this like the pipes, the blood vessels suddenly widening out everywhere, widespread vasodilation. This causes a severe drop in what we call systemic vascular resistance, or SVR. The actual blood volume might be okay, but there's just no pressure to push it around to the tissues effectively.
So the volume's there, but the pressure isn't.
Exactly. In trauma, we usually see this maybe a bit later, hours or even days out, often triggered by a massive inflammatory response, such as sepsis developing.
So the mechanism is totally different. Hypovolemic, the tank's emptying out. Distributive, the tank's full, but the hoses are suddenly way too wide. And
That's a great analogy. Then there's cardiogenic shock. This is a primary pump failure, maybe from a direct hit to the chest, a myocardial contusion, a bruised heart muscle, or sometimes a heart attack brought on by the sheer stress of the injury.
got it. So that would fall under cardiogenic shock, where the heart itself is damaged and can't pump effectively, even if blood volume is normal.
And finally, and this is super relevant for immediate trauma care, you have obstructive shock. This is purely mechanical. Something is physically blocking the heart from filling up or pumping blood out.
Tell me about the classic examples of obstructive shock, those immediate life threats we need to spot.
Things like a tension pneumothorax. Air builds up in the chest, collapses the lung, and actually shifts everything over.
So in this case, the tension pushes on the heart and great vessels.
Exactly. It physically kinks the big veins, returning blood to the heart, so cardiac output plummets. Or cardiac tamponade, blood filling the sac around the heart, right? Squeezing it so it can't relax and fill properly between beats. Both of these need immediate mechanical fixes, not just pouring in fluids.
Okay, this brings us to what I think is maybe one of the most critical takeaways here. The body's own response to shock, it's actually deceptive. It hides how bad things really are. How does the body try to compensate?
Well, the body immediately goes into full on emergency mode. It's the sympathetic nervous system kicking into high gear. Baroreceptors, sensors in the vessels, detect the drop in volume or pressure. They sound the alarm, triggering a massive surge of catecholamines, adrenaline, noradrenaline. This is what drives the compensatory mechanisms.
Right,
So, the first thing you'll typically see is tachycardia. The heart rate speeds up, trying to pump the remaining blood volume faster.
makes sense.
Second, you get profound vasoconstriction. The body clamps down blood vessels in non essential areas the skin, the gut, the limbs,
Shunting blood to the core.
exactly, prioritizing the brain and the heart. And this is why the patient's skin becomes cool, maybe clammy, even if the room isn't cold. That blood's being diverted away.
So the patient might look like they're coping heart rates up, maybe they seem anxious. But underneath, they're actually in a deepening crisis.
They are clearly in compensated shock, and it's inherently unstable. This leads us to probably the single most critical clinical pearl from all our sources. Hypotension, low blood pressure, is a late and truly ominous sign. By the time that blood pressure reading drops significantly, the patient has burned through all their reserves.
They've maxed out compensation.
They've maxed out, they've exhausted their catecholamine surge, their vasoconstriction can't keep up anymore, and they've tipped over into decompensated shock.
So just watching the blood pressure monitor, waiting for it to drop before acting,
Yeah,
that's a potentially fatal mistake.
it is. Absolutely.
What's the classic clinical error this compensatory phase leads to?
It very often leads to underestimating the severity of internal bleeding. A healthy young person, for instance, they can lose maybe 30% of their blood volume. That's up to 1.5 liters.
That's a lot of blood.
It's a lot. And yet, they might still maintain a systolic blood pressure that looks okay, maybe 100, 110, purely because of that maximal vasoconstriction.
Wow.
So if you wait for that pressure to fall below, say 90, you've basically waited until they're already deep into the danger zone, heading towards irreversible cell damage. You have to treat the whole picture, the fast heart rate, the cool skin, the anxiety or restlessness, not just that single blood pressure number.
That really hammers home the need for constant vigilance. Okay, let's also quickly touch on primary versus secondary shock. Why is that distinction important for ongoing care?
Right. So primary shock is the immediate hit, the hemorrhage right after the injury or the obstruction like tamponade. It happens right away. Secondary shock is sneakier. It's a delayed onset, sometimes hours later. It can creep up on the team.
Why is secondary shock so sneaky?
It could be missed injuries that weren't obvious initially, what we call occult injuries, or maybe slow, ongoing bleeding that just gradually depletes the remaining volume. Or it could be the body's systemic inflammatory response to the massive injury, leading to sepsis or complications like ischemia or reperfusion injury later on.
The initial resuscitation is just the start of the battle.
Yes, the existence of secondary shock means you can never let your guard down. That patient needs continuous high level reassessment. The initial fix isn't always the final fix.
Okay, with that physiological grounding, let's pivot to the action plan,
hmm
the rapid trauma roadmap. We're talking about that systematic approach, the ABCDE framework pioneered by ATLS. Our sources credit this framework with cutting preventable trauma deaths by a huge margin.
Yeah, the numbers are staggering. Sometimes up to 40% preventable deaths avoided with timely, structured intervention. And the ABCDE framework isn't just, a checklist, it's a hierarchy. It's based purely on what kills the patient fastest.
You fix the most immediate threat first.
Always, you start with what will cause death in minutes if not addressed.
Which brings us to A, airway. Airway obstruction is lethal. What specific signs should make us jump in immediately?
You have to be listening and looking. Stridor, that high pitched whistling sound that screams upper airway obstruction.
Okay.
Gurgling noises mean there's liquid blood, vomit in the airway. Hoarseness, or if the patient suddenly can't speak in full sentences, that could mean swelling or injury around the larynx is happening fast.
And if there is any major facial or neck injury.
In this case, assume the airway is threatened or will be soon. Assume swelling will close it off. You need to anticipate and act preemptively.
And linked inextricably with A is C, spine protection. Why is it so critical to maintain that manual inline stabilization even while we're trying to secure the airway, like during intubation?
Because any movement of the head or neck, extending it back, flexing it forward in a patient with a potentially unstable cervical spine fracture, can be devastating.
You could potentially cause paralysis.
You could cause permanent paralysis or even death from spinal cord damage or swelling right there. We must use airway techniques that minimize neck movement, keep that spine aligned until we have imaging that definitively rules out a significant C spine injury. It's non negotiable.
Okay. A is secure. C spine is protected. We move straight to B. Breathing and ventilation. Beyond just counting breaths, what are we assessing?
Quality over quantity here. We're checking the rate, yes, but also the depth of breathing, the effort involved. Are they using accessory muscles? Is the chest rising symmetrically? And critically listening to breath sounds on both sides.
And what are the immediate life threats we're listening for? You mentioned tension pneumothorax earlier.
Yeah.
What are those classic signs, again?
Tension pneumo is that ultimate obstructive emergency. Clinically, you're looking for severe respiratory distress, significantly diminished or totally absent breath sounds on one side.
The affected side.
On the affected side, yes, and the patient is usually deteriorating rapidly, becoming hypotensive. Later signs may be less reliable, are tracheal deviation, the windpipe shifting away from the injured side, or distended neck veins, JVD.
And the key clinical pearl you mentioned?
Treat the signs. Do not wait for a chest x ray if the clinical picture fits. If they're hypotensive, struggling to breathe, and breath sounds are gone on one side, needle decompression is needed.
Okay. What about other major chest threats, like an open pneumothorax known as the sucking chest wound? What's the immediate fix?
Right. That's air getting sucked directly into the chest cavity through a hole in the chest wall. You need to seal that hole immediately. We use an occlusive dressing, something airtight, like sterile plastic wrap or commercial chest seal. Major trauma protocols now recommend sealing the wound on all four sides. The older three-sided method was intended to act as a one-way valve, but it often fails in the real world because blood can glue the dressing down, or it may allow air to enter anyway. Because of the risk of a tension pneumothorax, standard practice is now to apply an occlusive seal and momentarily lift the edge of the seal if the patient shows signs of severe breathing distress.
Okay, rapidly moving on to C, circulation and hemorrhage control. This is where we tackle the number one killer in trauma bleeding. Beyond direct pressure or tourniquets for external bleeding, what's the immediate priority for access?
Access fast. We need reliable intravenous access immediately. The standard is aiming for two large bore IVs,
Large bore meaning?
meaning 14 or 16 gauge catheters, big ones, to allow for rapid infusion of fluids and blood products, usually placed in the antecubital fossa, the crooks of the elbows, or any other large peripheral vein you can find quickly.
And if you can't get those peripheral IVs in fast,
If you can't establish two good peripheral IVs quickly and that clock is ticking, the protocol immediately shifts. You go straight to IO, intraosseous access.
IO, into the bone marrow.
Yeah,
Why is that now so standard, even for adults?
because in a severely shocked patient, their peripheral veins collapse. They become incredibly difficult, sometimes impossible to cannulate. IO access bypasses that problem entirely. It allows you to infuse fluids and blood products directly into the bone marrow cavity, which contains a network of non collapsible venous sinusoids that drain directly into the central circulation. It's fast, reliable, and can handle high flow rates.
Where do you typically place an IO?
The two most common sites are the proximal tibia, just below the knee on the flat part of the shin bone, and the humeral head, the top of the upper arm bone near the shoulder.
Is one site preferred over another?
In profound shock, the humeral head is often preferred now because studies show it can achieve flow rates almost comparable to a central line. It provides really rapid access.
Okay, external bleeding controlled, access established. We quickly round out the primary survey with D and E.
Right, D is for disability. This is a quick neurological check. We often start with the AVPU scale, alert response to verbal stimuli, response to painful stimuli, or unresponsive. It gives you an instant snapshot.
If the patient is talking, that's a good sign.
If they're talking, you know their airway's patent, at least for now, and their brain is getting enough perfusion to maintain consciousness. Then we move to the Glasgow Coma Scale, the GCS, for a more detailed score from 3 to 15.
And what's the critical GCS number to remember?
The magic number is really 8 or less. A GCS of 8 or below is generally considered an absolute indication for definitive airway management, meaning patient needs to be intubated. The concern is they can't protect their own airway reflexes.
Got it. Less than or equal to 8. Intubate. Okay, and finally, E.
E is for exposure. You have to completely undress the patient, cut off all their clothing. You need to look everywhere, front, back, armpits, groin, to find any hidden injuries, penetrating wounds, or deformities.
But exposing the patient will drop their temperature. Isn't that counterintuitive?
Exactly. That's the immediate countermeasure. Exposure must be balanced immediately with hypothermia prevention. As soon as they're exposed for the exam, you cover them with warm blankets, use external warming devices like a bear hugger if available, because uncontrolled hypothermia is a fast track to that lethal triad we need to discuss.
That sets the stage for diving into advanced circulatory support. And this is where things have really changed, right? Let's talk about the big shift away from just pouring in fluids, crystalloids. Historically, that was the answer.
It absolutely was. For decades, the mantra was fill the tank with massive volumes of crystalloid fluids, normal saline, lactated ringers.
But our sources are emphatic now. That practice is strongly discouraged. Why? What's the evidence against it?
The evidence is really overwhelming now. We thought restoring volume was the key, but flooding the system with crystalloids causes major problems. The first big one is dilutional coagulopathy.
Diluting the clotting factors.
Precisely. You're pouring in liters of fluid that contain zero clotting factors, zero platelets. So you dilute the patient's own remaining factors and platelets, making it harder for them to form clots. You actually make them bleed more.
So, the treatment worsens the primary problem. What else?
Well, it hits two other parts of that lethal triad we just mentioned. It worsens hypothermia because you're infusing room temperature or even cold fluid directly into their core.
Chilling them from the inside out.
Exactly, and it worsens acidosis. Normal saline, for example, isn't pH neutral. Large volumes can cause a hyperchloremic metabolic acidosis, and even LR can be problematic in huge amounts. Plus, crystalloids don't stay in the blood vessels very well.
Crystalloids are problematic because they leak out.
They leak into the tissues very quickly, the so called third spacing. This causes widespread edema, swelling in the limbs, gut, and dangerously in the lungs, increasing the risk of complications like acute respiratory distress syndrome down the line.
Okay, so less crystalloid. This leads directly to this really counterintuitive strategy, permissive hypotension. How on earth do we justify deliberately keeping a bleeding patient's blood pressure low?
It sounds wrong, doesn't it? But the rationale is mechanical, and crucially, it's a temporary bridge to definitive hemorrhage control, usually surgery. When you have active uncontrolled bleeding, aggressively pushing fluids or blood products to raise the pressure back to normal can actually be harmful. That high pressure can literally blow off the fragile clots the body is desperately trying to form at the injury site.
Like turning up the pressure on a leaky pipe.
Exactly. You're just increasing the hydrostatic pressure and disrupting nature's attempt to seal the leak.
So, what's the target then with permissive hypotension?
The goal is to maintain a systolic blood pressure that's just high enough to ensure adequate perfusion to the vital organs, the brain and the heart, but low enough to minimize further bleeding and allow clots to stabilize. The target range is generally a systolic pressure around 80 to 90.
80 to 90 systolic. Is there a quick clinical sign?
A good bedside trick is often maintaining a palpable radial pulse at the wrist. If you can feel that pulse, their systolic pressure is likely above 80 millimeters of mercury. That tells you perfusion is probably adequate for this temporary phase.
So, the focus shifts entirely from achieving a normal BP to hitting this target low BP just until the bleeding has stopped surgically or procedurally.
Correct. It's a bridge strategy.
But this strategy is absolutely contraindicated in one specific group of trauma patients.
Cannot emphasize this enough. Permissive hypotension is absolutely contraindicated in patients with suspected or confirmed traumatic brain injury, TBI.
Why the exception for head injuries?
Because the injured brain is incredibly sensitive to ischemia, to lack of blood flow. We need to maintain an adequate mean arterial pressure MAP to ensure sufficient cerebral perfusion pressure, CPP, the pressure gradient that drives blood flow to the brain. Allowing hypotension in a TBI patient essentially guarantees secondary brain injury from lack of oxygen. You must keep their pressure up.
Okay, critical distinction. Now, if the bleeding is obviously catastrophic, seems unlikely to stop on its own, or we anticipate massive blood loss, that's when we trigger the big guns. The massive transfusion protocol, or MTP. What's the threshold for hitting that button?
Yeah. Activating the MTP is a major decision. It's typically triggered based on clinical signs, ongoing severe hypotension, despite initial efforts, obvious signs of uncontrolled hemorrhage like pooling blood, penetrating torso trauma, or if you anticipate needing more than, say, 4 units of packed red blood cells, PRBCs, within the first hour. Some scoring systems exist too, like the ABC score.
And when MTP is activated, the philosophy shifts again, right, to balanced resuscitation?
Absolutely. We move away from just giving red cells and focus on replacing all the components the patient is losing, trying to mimic whole blood as closely as possible.
And what does balanced mean in practice? What's the magic ratio?
The current gold standard, strongly supported by evidence from military and civilian trauma studies, is aiming for a 1:1:1 ratio of packed red blood cells, PRBCs, fresh frozen plasma, FFP, and platelets.
1 unit of red cells, 1 unit of plasma, 1 unit of platelets. Let's break down why that specific ratio is so important, so life saving.
Okay. Each component addresses a specific critical deficit caused by massive hemorrhage and resuscitation efforts.
Start with red cells.
PRBCs obviously restore oxygen carrying capacity. That's fundamental. You need hemoglobin to deliver oxygen to those starving tissues.
Okay. Then plasma.
Plasma is crucial because it contains all the clotting factors fibrinogen, prothrombin, all the proteins needed for the coagulation cascade to work. Hemorrhage and crystalloid dilution rapidly deplete these factors. Giving plasma replenishes them.
And the platelets?
Platelets are the physical plugs. They aggregate at the site of injury to form the initial clot. They're also rapidly consumed and diluted during massive bleeding. So, giving platelets restores the ability to form that primary plug.
So by giving them together in that balanced 1:1:1 ratio.
You're simultaneously tackling the oxygen deficit, the clotting factor deficiency, and the platelet dysfunction. You're addressing all three arms of the crisis at once. This approach has been shown to significantly reduce mortality and decrease the risk of that dreaded trauma induced coagulopathy.
Right? And if we fail to manage all this effectively, the volume, the blood products, the temperature, the patient spirals into that catastrophic cycle you mentioned earlier, the lethal triad. Let's really unpack this because it sounds like a point of no return.
It almost is. The three components, hypothermia, coagulopathy, and acidosis, are viciously interconnected. Once that cycle gets going, it feeds itself and it becomes incredibly difficult to break.
Okay, start with hypothermia. How does being cold make you bleed more?
When the core body temperature drops below about 35 degrees Celsius, 95 Fahrenheit, critical enzyme systems start to malfunction, specifically the enzymes involved in the clotting cascade. The complex chain reaction that forms a stable blood clot simply don't work effectively in the cold.
So, a cold patient literally cannot clot properly.
They cannot clot properly, period.
And if they can't clot, they bleed more, which links to the second point.
Exactly. Increased uncontrolled bleeding directly drives the coagulopathy. As they bleed, they're losing more clotting factors, more platelets. The dilution from any resuscitation fluids makes it even worse. It becomes a self perpetuating hemorrhage,
More bleeding means less blood flow.
which means worsening tissue hypoperfusion, and that leads directly to the third component, acidosis.
From that anaerobic metabolism we talked about earlier.
Right. The poorly perfused tissues are screaming for oxygen. They switch to anaerobic metabolism, pumping out massive amounts of lactic acid. This severe metabolic acidosis poisons the system.
How does acidosis worsen things further?
Acidosis does two terrible things here. First, it further impairs the function of those already struggling clotting enzymes, making the coagulopathy even worse. Second, it directly depresses myocardial contractility. It makes the heart muscle weaker and less efficient.
So the pump fails even more.
The weak heart pumps less blood, worsening perfusion, which generates more acid, which worsens clotting and heart function, and the cycle just spins faster and faster downwards.
It sounds truly like a biological death spiral.
Yeah.
So the intervention, especially for nursing teams' rapid response, has to be focused on breaking that cycle early, particularly hitting the hypothermia piece hard.
Interrupting the cycle is everything, and aggressively preventing and treating hypothermia is absolutely non negotiable. This isn't just about comfort, it's physiology.
What does that mean in practice?
It means active warming measures from the second the patient arrives. Warm blankets are a start, but often not enough. Forced air warming devices like the Bear Hugger are essential, and critically, using fluid warmers for all IV fluids and especially all blood products being infused. You cannot give cold blood to a cold bleeding patient.
And simultaneously addressing the other two problems at hand.
Simultaneously, yes, you need effective resuscitation to reverse the acidosis, getting oxygen and perfusion back to the tissues with balanced blood products. And that balanced 1-to-1-to-1 transfusion strategy directly combats the coagulopathy by replacing what's being lost. You have to fight all three fronts at once.
Okay. That covers the circulation nightmare. Let's move into trauma pharmacology and targeted interventions, specific drugs for specific problems, starting with the big one, tranexamic acid or TXA. You called this non-negotiable earlier. Why is TXA so vital now?
TXA is an antifibrinolytic agent. What it does is prevent the breakdown of blood clots once they've formed.
So it doesn't help form the clot, but helps it stick around.
Exactly. It inhibits an enzyme system, specifically the conversion of plasminogen to plasmin, which is responsible for dissolving clots, fibrinolysis. In trauma, especially early on, there can be excessive fibrinolysis contributing to the bleeding. TXA helps stabilize the clots the patient is forming.
And the evidence for using it is strong.
Very strong. Large landmark trials, particularly the CRASH H2 trial, involving thousands of trauma patients worldwide, showed a significant reduction in death from bleeding and even all-cause mortality when TXA was given early.
Okay. Early is the key word there. What's the critical lesson about TXA from those trials? It's all about the timing, isn't it?
It is entirely about the timing. The window is tight and absolute. TXA gives its maximum benefit, the mortality reduction only when administered within 3 hours of the time of injury.
3 hours from injury, not from hospital arrival?
Correct, from the moment of injury. And the benefit is actually strongest if given within the first hour.
What happens if you give it later, after 3 hours?
Giving TXA after the 3 hour mark is actively discouraged, even potentially harmful. The data suggests that late administration might actually increase the risk of thromboembolic events, blood clots forming where you don't want them, like DVTs or pulmonary emboli, without providing any mortality benefit. The risk benefit balance flips completely after 3 hours.
So you have to think of TXA, like a time critical drug for stroke or heart attack. There's a hard deadline.
Precisely. That clock starts ticking the moment the injury occurs. Standard dosing is usually 1 gram bolus over 10 minutes, followed by another 1 gram infused over the next 8 hours.
Got it? TXA early. Next up, vasoactive agents, the pressors. If we're focused on replacing volume with blood, when do drugs like norepinephrine come into play?
It's important to remember that vasopressors are generally considered adjuncts only in hemorrhagic shock. They are absolutely not a substitute for volume replacement with blood products. You can't squeeze an empty tank effectively.
So when are they used?
They might be used temporarily if blood products aren't immediately available, or if hypotension persists despite adequate volume resuscitation, suggesting maybe a component of vasodilation, or crucially, they are the primary treatment in certain states like neurogenic, where the core problem is vasodilation.
And which pressor is preferred in trauma?
Norepinephrine, also known as Levophed, is generally the first line agent.
Why norepinephrine over, say, dopamine, which used to be common?
Norepinephrine hits the sweet spot for many trauma scenarios. It provides potent vasoconstriction through its alpha adrenergic effects, which helps restore vascular tone and increase blood pressure, particularly when SVR is low. But importantly, it has less effect on heart rate and potentially fewer cardiac side effects, like arrhythmias, compared to dopamine. Dopamine's effects can be more variable and less targeted to the specific need for vasoconstriction in many states.
Okay, norepinephrine is the go-to pressor when needed. Now let's talk pain control. We know uncontrolled pain is bad. It's a stressor, increases oxygen demand, and worsens shock physiology.
Absolutely.
But the typical strong pain meds, opioids like morphine or fentanyl, or sedatives like benzodiazepines, they often drop the blood pressure. How do we manage severe pain in a patient who's already hemodynamically unstable?
This is a classic trauma dilemma, and it requires picking the right tool for the job. The agent that really shines in this situation, the one preferred for the hypotensive or unstable trauma patient needing analgesia and potentially sedation, is ketamine.
Ketamine. That's interesting. It has a bit of a reputation. Why is it the choice during resuscitation here?
Ketamine is unique pharmacologically, especially in the doses used for analgesia and procedural sedation. Unlike most other anesthetics and analgesics, it actually stimulates the sympathetic nervous system.
It supports the blood pressure.
It tends to support or even mildly increase blood pressure and heart rate because it causes the release of the patient's own endogenous catecholamines, their own adrenaline. So while it's providing excellent pain relief and often a dissociative state, it's doing so without tanking the patient's hemodynamics. Opioids and benzos, in contrast, can cause significant vasodilation and respiratory depression, making the shock state worse.
So ketamine lets you treat the pain without sacrificing the circulation.
Exactly. It allows you to address the physiological stress of pain while maintaining or even supporting cardiovascular stability. It's a critical tool in that unstable patient. It fundamentally changes the risk benefit equation for analgesia in trauma.
That's a really key point, a major departure from maybe standard practice outside of trauma. Okay, let's quickly circle back to those immediate thoracic emergencies needing action based purely on clinical signs. Tension pneumothorax, you suspect it. What's the immediate action and where do you do it?
If you suspect tension pneumothorax based on those clinical signs, respiratory distress, absent breath sounds, hypotension, maybe tracheal deviation, or JVD, the immediate life-saving intervention is needle decompression. You need to notify the doctor and let that trapped air out now.
Where does the needle go?
Historically, the go-to spot the doctor used to insert the needle was the second intercostal space mid-clavicular line, sort of high up on the front of the chest. However, current guidelines often favor an alternative site. The fifth intercostal space, just anterior to the mid-axillary line, basically on the side of the chest level, with the nipple in males.
Why a change in the location?
Several reasons. The chest wall tends to be thinner at the fifth ICS site, meaning a standard length catheter is more likely to actually reach the pleural space. There's also arguably less risk of injuring major underlying structures compared to the second ICS approach. It's considered safer and potentially more affected by many protocols now. But the key is recognize it, act fast, get the needle in.
Okay, great clarification on location. We've covered volume loss extensively. Now we need to differentiate the shock states that break the usual rules. Let's start with neurogenic shock. How does a high spinal cord injury completely flip the script on the body's response?
Neurogenic shock is fundamentally different. It's a type of distributive caused by severe damage to the spinal cord, usually high up at T6 or above.
Thoracic level 6 or higher?
Right. What happens is a complete interruption of the sympathetic nervous system outflow below the level of that injury. The fight or flight signals just can't get down.
So, what does that disruption do to the body?
Two main things. First, without sympathetic signals telling the blood vessels to constrict, you get profound vasodilation below the level of injury. The vascular container gets huge. Second, the parasympathetic system, which originates higher up in the brainstem and travels down the vagus nerve, is now left unopposed. The sympathetic accelerator is cut off, but the parasympathetic brake is still fully functional.
And that leads to?
It leads to the absolute hallmark signs that are completely opposite to what you see in hypovolemic shock. Instead of tachycardia and cool, clammy skin, the patient with neurogenic shock typically presents with hypotension combined with bradycardia, a slow heart rate.
Low pressure and a slow heart rate. That's the key differentiator.
That's the classic defining feature. The lack of compensatory tachycardia is critical, and because of the widespread vasodilation below the injury level, their skin is often warm and dry, not cool and clammy.
So, if you have a trauma patient, especially after blunt trauma, suggesting potential spine injury, and they're hypotensive, but their heart rate is slow or normal, you have to think neurogenic shock, not just bleeding.
Immediately. It should jump right to the top of your radar.
And how does the treatment have to differ from hypovolemic? Fluids aren't the main answer here.
Fluids might help temporarily fill that massively dilated vascular space, but they won't fix the underlying problem, which is the loss of vascular tone. Pouring in fluids alone is often insufficient and can lead to fluid overload.
So, what is the primary treatment?
The primary treatment requires vasopressors. You need drugs, typically norepinephrine again, to artificially restore that lost sympathetic tone and squeeze the blood vessels peripherally. You might also need drugs like atropine to counteract the severe bradycardia caused by that unopposed vagal parasympathetic tone. It's about restoring tone, not just volume.
Okay, that's a critical distinction. Now, the other major rule breaker is obstructive shock. We talked about tension pneumo. Let's flush out cardiac tamponade. What are those three classic signs again of Beck's triad?
Right. Cardiac tamponade is that mechanical compression of the heart from fluid, usually blood and trauma trapped in the pericardial sac around it. Beck's triad is the classic description, although it's not always present, especially early on. The triad consists of 1, hypotension. The heart simply can't pump effectively because it can't fill properly. Cardiac output drops.
Okay, what are we looking for next?
Next, we are listening for muffled heart sounds. Listening with a stethoscope, the heart sounds are faint, distant because the fluid is insulating the sound. And 3, jugular venous distension, JVD. The neck veins bulge because blood is backing up into the venous system. The heart's right side can't accept the venous return because it's being squeezed.
Hypotension, muffled sounds, JVD. If you suspect tamponade or confirm it, say with ultrasound, what's the immediate definitive fix?
The definitive life-saving intervention is pericardiocentesis. You need to get that fluid out from around the heart fast.
Sticking a needle into the pericardial sac?
Exactly. The doctor will stick the patient, usually guided by ultrasound if possible. A needle and syringe are used to aspirate the blood or fluid from the pericardial space. Removing even a small amount can dramatically relieve the pressure on the heart, allowing it to fill and beat properly again, restoring cardiac output almost instantly. It buys time for definitive surgical repair if needed.
Okay. We spent a lot of time on that golden hour, the immediate fixes. But the fight isn't over when the initial bleeding stops or the chest is drained. Let's look at the long game. Complications and team dynamics. The very act of saving the patient initially can set them up for problems later.
That's absolutely the paradox of critical care and trauma. The initial massive injury combined with the necessary aggressive resuscitation efforts, fluids, blood pressors, triggers this huge systemic inflammatory response. It's often an uncontrolled cascade that can lead to severe delayed complications days or even weeks later.
Let's start with trauma-induced coagulopathy. Yeah, we touched on dilution, but you mentioned it's more complex. It starts with the injury itself.
Yes, coagulopathy induced by trauma is not just about washing out clotting factors, although that contributes. It's now understood to be an endogenous process that starts very early, triggered by the severity of the tissue damage and shock state itself.
What does it involve?
It's complex, but key features include activation of anticoagulant pathways, and importantly, a state called hyperfibrinolysis, where the body starts breaking down clots too quickly. This is then massively exacerbated by the hypothermia, acidosis, and hemodilution we discussed.
So it's a perfect storm for uncontrolled bleeding.
Exactly. If trauma induced coagulopathy is not recognized and treated aggressively, primarily with that balanced 1 to 1 to 1 MTP approach and early TXA to combat the hyperfibrinolysis, the patient can continue to bleed uncontrollably even if the surgeon thinks they've fixed the primary source. It's a major driver of mortality.
Okay, moving from blood to lungs. The next big delayed threat is acute respiratory distress syndrome, or ARDS.
ARDS is a devastating lung injury. It's basically non cardiogenic pulmonary edema fluid leaking into the air sacs, alveoli, but it's caused by inflammation, not heart failure. This leads to severe hypoxemia, difficulty oxygenating the blood.
Who's most at risk for ARDS after trauma?
Several groups, patients with direct lung injury like pulmonary contusions, bruised lungs, patients who receive massive volumes of crystalloid resuscitation early on are at higher risk, and patients who develop sepsis following their trauma are also very prone to ARDS.
And managing ARDS is quite the challenge.
Very tough. It requires intensive care, mechanical ventilation, and very specific strategies. The key is lung protective ventilation.
What does that mean?
It means using low tidal volumes, smaller breath sizes delivered by the ventilator to avoid overstretching and further injuring the already damaged lung tissue. This is called preventing ventilator induced lung injury. It often involves allowing higher levels of CO2, permissive hypercapnia, and using PEEP, positive end expiratory pressure, carefully to keep the stiff, fluid filled alveoli open, improving oxygenation without causing more damage. It's a delicate balancing act.
And if multiple organs start failing due to this systemic inflammation and ongoing shock, that leads to the leading cause of late trauma deaths.
That's multi organ dysfunction syndrome, or MODS. It's defined as the progressive failure of two or more vital organ systems, typically the lungs, ARDS, kidneys, acute kidney injury, liver, coagulation system, sometimes the brain,
When does MODS typically show up?
usually days to weeks after the initial injury and resuscitation. That initial inflammatory storm, ongoing low level hypoperfusion, maybe secondary infections, it all contributes to microvascular damage and dysfunction in distant organs. They just start to shut down.
What are the subtle signs the team in the ICU needs to be watching for to catch MODS early?
Constant monitoring is key. For the kidneys, you're watching urine output closely. Oliguria, low urine output, despite what seems like adequate fluid intake, is a major red flag. Rising creatinine levels confirm kidney injury, often progressing to needing dialysis or continuous renal replacement therapy.
What about other organs that might be affected?
For the liver, watch for rising bilirubin levels, jaundice, abnormal liver function tests, and worsening coagulopathy since the liver makes clotting factors. For the brain, subtle signs like unexplained confusion, agitation, or lethargy. Altered mental status can indicate CNS dysfunction as part of MODS. Catching these trends early is critical because once organs fail completely, it's often irreversible.
Okay. This paints a picture of extreme complexity, both physiologically and in terms of long-term care. Which brings us finally to the human element, trauma team dynamics. All this advanced knowledge is useless if the team in the trauma bay can't execute it flawlessly under immense pressure. How does organization actually save lives in that chaos?
It's absolutely fundamental. Effective trauma care relies on structured well rehearsed teamwork, often moving away from traditional hierarchies. The cornerstone is structured leadership.
Meaning one person is clearly in charge.
Yes, there is a designated trauma team leader. Their job isn't necessarily to do all the procedures, but to stand back slightly, assess the big picture, establish clear priorities based on the ABCDEs, delegate specific tasks to pre assigned team roles like airway, IV access, chest procedures, scribe, and constantly maintain situational awareness.
What's situational awareness in this context?
It's having a shared mental model across the whole team. Everyone understands the patient's current status, the suspected injuries, the interventions being done, and crucially anticipates what might happen next, like predicting massive hemorrhage, losing the airway, or the need for MTP activation. Delegation ensures you don't have three people trying to start an IV while nobody is reassessing breathing.
And communication within that team has to be precise to avoid errors.
This is critical. The standard is closed loop communication. It's a simple but vital error prevention tool.
How does it work?
The sender gives a clear, concise order. For example, the leader says, Nurse A, give 1 gram of TXA IV now. Nurse A must repeat the order back verbatim, giving 1 gram TXA IV now. And the leader must confirm, confirmed, or correct.
So everyone knows the message was received and understood correctly.
Exactly. It eliminates ambiguity, prevents errors from mishearing or assumption, especially in a noisy, high stress environment. And part of good team dynamics is also empowering all team members, regardless of their role or seniority, to speak up immediately if they see something wrong, if they have a concern, or if they notice a change in the patient that maybe the leader hasn't spotted yet. It's about flattening the hierarchy for safety.
This entire podcast, it feels like it's fundamentally shifted the picture of how we approach trauma resuscitation. We've really moved away from some old rules.
Definitely. The days of just blindly pouring in crystalloids or waiting for that blood pressure number to drop are, or certainly should be, gone. It's about precision, early and aggressive use of blood products in a balanced way, anticipating complications, and working as a highly structured team.
So, to try and pull these threads together for you, the listener, let's recap some of those core shifts, those key takeaways. First, probably the biggest one: never ever trust a normal blood pressure in an acutely injured trauma patient. Hypotension is a late catastrophic sign. You need to act on the earlier signs: tachycardia, cool skin, and altered mental status.
Treat the patient, not the monitor number.
Second, the whole approach to circulation has changed. Avoid those massive crystalloid infusions. Embrace permissive hypotension, aiming for that systolic of 80 to 90 as a temporary bridge until the bleeding is surgically controlled. But remember that huge exception not in head injury patients. They need higher pressures to perfuse the brain.
That is a critical exception.
Third, when you do need to replace volume, think balanced resuscitation. That 1-to-1-to-1 ratio of PRBCs, plasma, and platelets is key for managing massive hemorrhage. And get that TXA in early. That 3-hour window from injury is absolute. Maximum benefit is within the first hour.
Time is critical for TXA.
And finally, recognize those specific shock patterns that break the mold, especially neurogenic shock after potential spinal injury. Look for that weird combination of hypotension and bradycardia, often with warm skin. It needs pressors, not just fluids.
Understanding those different shock physiologies is key to targeted treatment.
It seems like successful trauma care is less about heroic improvisation and more about this highly choreographed, almost algorithmic response to chaos. It demands applying protocols and evidence, even when it feels counterintuitive.
It really does. It requires skills and adherence to protocols that sometimes run directly against maybe a natural human instinct to just, make all the numbers look normal as quickly as possible. Well, Nate, that brings us to the end of today's conversation. As you head back into your shift or into whatever season of life you're in, we hope you'll keep your curiosity alive. Keep asking why, keep sharpening your clinical judgment, and keep choosing the kind of care that's timely, evidence-based, and deeply human. And when the system gets loud, remember your voice matters. Keep showing up with confidence.
If you're ready to go deeper, enroll in our full 10-hour CE course on trauma shock. Don't let license renewal sneak up on you. Get your accredited CE courses and download certificates instantly. Finish your hours and get back to life. ConfidentNurse.com